So perhaps if we could just start by introducing ourselves, and for the purpose of when this goes up on the website, if after I've introduced us, perhaps you could introduce yourself formally and say who you are, etc., so that we've got a proper record. Just one of the things that we've been asking people is whether they've got conflicts of interest. And I don't think we've actually had anything from you on that particular subject yet. So I don't know if you want to say anything right now, or whether you would send us something later.
I have no conflicts of interest, financial or otherwise. But obviously I've been involved in a range of guidelines committees over the years, and that will bear relevance on my perspective of matters.
Right, that's good. Thank you very much. So I'm Julia Cumberledge, and I was invited by the Secretary of State to chair this review. And I just felt it was very important that I got the best people I could around me. And so we've achieved that. And so on my left is Cecile Chandler, who probably you know, but is hugely respected throughout the lab. And on my right is Simon Whale, and Simon is particularly looking at communications and things, but he's part of the 3 panel that we've got. But of course we need very high-level support. And so on Simon's right is Dr. Valerie Brass, who is our secretary. And on Cyril's left is Sonia MacLeod, who is our principal researcher. And then we've got other people in the room who are just here to help us make sure we run this correctly. So if you, just for the camera, if you could just say who you are and what your position is, that would be helpful.
So my name's Andrew Baranowsk. I'm a consultant in pelvic pain medicine and neuromodulation. I'm based at the National Hospital for Neurology and Neurosurgery, Queen Square, which is a part of UCLH NHS Foundation Trust. I've been involved in the management of those living with chronic pelvic pain for 25 years. I've been running dedicated pelvic pain clinics using the multidisciplinary team model for over 20 years. I've been running joint clinics with urogynecologists, neurosurgeons, radiologists, rheumatologists for much of that time. I've been involved, as I suggested earlier, in guidelines as a panel member of the European Association of Chronic Pelvic Pain Guidelines, which is highly respected as an education and training tool in the United Kingdom for chronic pelvic pain since 2004. I led the British Pain Society's maps for pain, including and took part in the map for care of pelvic pain. I've written widely on the subject, lectured on the subject, and I was the immediate past chair of NHS England's Clinical Reference Group for Highly Specialised Pain Services, and I'm currently president of the British Pain Society.
Right. Well, very interesting career. Thank you very much. Can I just say that listening a lot to the patient groups, and we have heard a huge amount from them, we've had complaints from women that there really doesn't seem to be any formalised pathways, and it's almost a sort of matter of luck whether they get referred to the correct services. And I just wondered if you could say whether you feel that these pathways are clear, and whether women are given enough information to know how to access them.
I think the guidelines, the pathways, are quite clear. I think that the service specification of highly specialised pain services that I drew up, which was the D08 specification, made it quite clear as to how it should fit together, and I think it's still in draft format, but the latest version, which is the D07, quite clearly talks about pathways of care in terms of providing appropriate expertise local to where the patient lives, but then referral onwards to more highly specialised services as appropriate. So it's seeing the right specialist at the right time, local where possible, at a more regional or national centre where necessary. The problem with the pathways then is, whereas the professionals have defined them, I would say the problem is a lack of resources to actually provide them clinically, rather than actually they're not defined.
So obviously this is seen very much through the specialists, through the people who are providing pain clinics and things like that. But how does that information get to women? Because at the moment they're saying that it's purely by luck whether they get to a very good specialist who's going to address their problems.
So if you're talking about pain specifically, then there are only 4 or 5 centres in the United Kingdom that can provide highly specialised pelvic pain services. And therefore it's done basically by word of mouth amongst the clinicians. So most, if not all, of my pain management colleagues would know about the services that patients can access. There is obviously interaction between pain speciality and other specialities in terms of education, providing lectures and so on, but that is informal. So the patients are quite correct in saying that it is very easy for them to go around in circles. One of the issues that I'm dealing with at the moment, I'm sorry to say this is particularly a problem in the private sector, is where patients go around in circles from one person to the other locally, as opposed to having an umbrella opinion. So I believe that one of the suggestions is that there should be localised mesh centres, the number of which is not for me to determine. All of those services should have a consultant with an interest in pelvic pain associated with it, and any highly specialised pain services should then have highly specialised clinicians involved in it who've got the experience and the knowledge. So it's only by having the clinical pathways, I think, that the patients will access them. Obviously, there's information on the British Pain Society website and the patient forums, through the Twitter campaign, this, that and the other. They know about the different systems to that, but that's all informal.
Yes, please.
If I understand it correctly, you're saying that there are 5 specialised centres recognised by the British Pain Society dealing with pelvic pain. Are they recognised by NHS England? Because you mentioned that they weren't appropriately resourced.
I'm not saying so. There is then this issue about the role of the professional societies in recognising different departments, and that's probably not an appropriate thing for me to discuss. So the British Pain Society purposely does not recognise centres. It provides education training.
But then who does recognise them?
So NHS England service specification clearly states what those services are, and then the commissioning, NHS England commissioner, the specialised services commissioning body would recognise them.
So are you specialised? You're supported by specialist commissioning?
Yes.
I see.
And it's those commissioners that recognise the services, not the British Pain Society.
Right. Well, there is the plan, which is now being developed as part of the pause, for specialised mesh removal centres to be also supported with specialised commissioning and accredited appropriately. Would there be coterminosity then between the pelvic pain centres and those mesh removal centres?
So when I was chair of NHS England's clinical reference group for highly specialised adult pain services, pain was acknowledged as being a cornerstone for any other highly specialised service. The problem has always been that pain management is considered a Cinderella speciality, and then when I talk about lack of investment, you will find that a lot of clinicians are working on their own without appropriate support from trained pain management physiotherapists, psychologists, nurses, and that they're struggling. As far as I'm concerned, there should not be a highly specialised pain mesh removal service without involvement of a highly specialised pain management team, which does not mean just a doctor.
No.
It means a team of doctors helping the patients. So the model at University College London is a model where I've been supported, and I started off with myself, my nurse who still works for me 25 years on, psychologist who works around the corner, a physio who works for me 25 years on, and a consultant whose retirement do I go to after this meeting. Now we have a team of 90 people because the hospital has supported us, and we can provide psychology, physiotherapy, and dedicated nursing on drug reductions, drug manipulations, neuromodulation, and all those things. Therefore, that is what I would advocate, personal view, obviously, that's what should be available at those highly specialised services. My understanding is that there will be some services who will be removing mesh on the grounds, or we probably need to discuss about removing mesh as a separate issue, but if the decision is to remove mesh, there will be some services that will remove it based on the grounds that there's an infection, there's an ulceration, there's an erosion, and that would be one group of services, because looking at the numbers of people involved in this, 6 services will never be able to do that. Then there'll be, as I understand it, and you probably know more than me, a number of highly specialised services. So the first set should have pain clinics attached to them. The highly specialised should have highly specialised pain services attached, and that should be something that NHS England should lead on.
So can I just ask you, I mean, it's very interesting. Clearly, yours is a model you would like to see replicated in these other centres, but you're talking about 4 or 5 centres.
Yes.
And I'm just thinking about these women who are in excruciating pain,
Yes.
that actually they're finding it extremely hard to travel at all. And, you know, accessibility is actually very, very difficult for them. And so they obviously go to places where there isn't quite the same specialism, there isn't quite the same setup that you've got, which is clearly resource intensive. So how about those women? What do you do with those who are not in your profession, in the area that you work in, that are not specialists? What do you do with those people who are giving some advice to women, but clearly for some women it has been a waste of time?
So, as I was saying, I'm trying to make a point that actually there should be pathways of care, and those pathways of care exist. And so the problem is, to some extent, the area you're talking about in terms of lack of resources in those areas.
How big is the resource gap?
I can't give you an actual figure, but if you look at the map of England where they say, what the clinics is, it's really quite bad. There are big gaps where there aren't pain services. And one of the problems when you look at I can't remember the name of the map of distribution of services, but when you look at that, I think there's 600 pain doctors in the country, and a lot of them are working independently.
So they're not part of a team. So I mean, in terms
so they're hardly supported, yes.
Yeah. But I mean, in terms of the capacity within the system to enable patients to access specialist services, are you saying that?
So we talk about speciality and specialised services, and it's the speciality services we're talking about, and many of those doctors are working independently and under pressure. And if we look at the impact of pelvic pain on the quality of life, pain in its own right, in the more severe end, has a greater impact on quality of life than most serious conditions. If you then throw into that pelvic pain, where you've got the patients who can't sit down, they get debilitated, and then you get all the comorbidities. So in the pain service, we have to look at things like, it's not just the mesh, the results of having chronic pelvic pain are not just localised, they become regionalised. Therefore, these patients will possibly have primary bladder conditions as a result of what got them to where they are at the moment. But we know that this group of patients will also then have secondary phenomena related to the chronic pain mechanisms. So the World Health Authority now acknowledges that pain is a primary condition in its own right, ICD-11. That means that you can have pain without an obvious pathology such as infection and erosion or whatever. Those mechanisms are in the central nervous system, and that results in a centralised process which affects other organs. So one of the problems I understand is that patients are not being listened to because they've got a small piece of mesh and they're complaining of bowel, bladder, sexual dysfunction, and then they're complaining about systemic disorders. There is good evidence that in the bladder pain syndromes, that the systemic disorders are modulated or mediated by the central nervous system. So in non-mesh patients with bladder pain disorders, we see a higher incidence of chronic widespread pain syndrome, fibromyalgia, and nerve terminal chronic fatigue. But you also see a higher incidence of autoimmune disorders such as Sjogren's disease, dry eye itch syndrome, and you see a higher incidence of endocrine abnormalities such as hypothyroidism. So the phenomena that these ladies are describing have a scientific background and basis which can be substantiated. So when we're looking at these people, there's going to be major issues on the ground that cannot be dealt with by lone consultants. They need to be working as a part of a team, and they need to be working with appropriately trained pain management psychologists, appropriately trained pain management physiotherapists, where the approach is different to hands-on physiotherapy, but there's that interaction. And of course, clinical nurse specialists. My nurses are running the show whilst I'm here.
So how successful are your treatments? How many women actually go to these specialist centres and then actually find that it's been pretty ineffective?
I think it depends what you're looking for, and I was thinking about this in terms of mesh removal earlier. And I think it comes down to patient expectations and what they're looking for. What we have to acknowledge is that pain is multimodal and it's associated with a huge impact on quality of life. So emotional distress, depression, anxiety, health anxieties, fears, social breakdown, marital breakdown, sexual relations falling apart, and all of those things. So pain is multidimensional. If you're looking for purely a reduction in pain, then the outcome of the procedures is limited. But there are certain things such as, if it's appropriate, neuromodulation, electrical stimulation of the nerves and so on, and in that you may see a 30 or 50% reduction in the pain. The problem is, a part of the issue, which is why I emphasise the MBT, is that actually any treatment is doomed to fail unless you take on board the concerns of the patients, the psychological and the behavioural ability to do things, the behavioural impact of the pain. All physical treatments are going to be a problem. And I'm thinking of patients I've seen recently whereby the issue has then been about tape removal. Now, as a non-surgeon, there's clear indications when you might want to remove tape. We're going to get into problems when we have these issues where the patient wants the tape removed and there's a question about actually what is going to be the outcome of that. So it's not only about the outcome of the pain management interventions, it's the outcome of any intervention for pain. If you're not addressing and supporting the patients in terms of understanding what the outcome is going to be, and that could be an accusation of putting the meshes in the first place, is that they didn't have informed consent. And when you've got a distressed patient who's suffering, how can they give informed consent unless you're addressing that? And so unless you're looking at pain management strategies in terms of medications, possibly drugs and various things like that, and injections, but then you need to combine into that the psychology support and the physical support so that you have a stable position to work from. Complicated answer for a complicated question. But that's why you need the team, and that's why people working on their own struggle.
Thank you very much.
Can I ask whether you know how many women suffering mesh complications get referred to pain clinics?
Small proportion. It's a small proportion, I think, which is what you're saying. That's the patient experience.
Does the British Pain Society
We don't collect
any data on that?
And no one has collected that data. We've just started collecting that data in our departments to look at the number of patients that we see. And this in January we referred 12 patients, and we think that's an increase in number. Now 12 patients may not sound much, it isn't in the scheme of things, but actually that is the work for a team, in a sense, in a month, to see 12 patients.
Are they all mesh related?
Those are the mesh related patients.
Right.
Okay. And I don't know what I'd be guessing if I said we get 100 referrals, but I would easily imagine it's going to increase from 5 to 10% up.
So it's around 5 to 10%.
I'm guessing.
Yeah. And if you think over the last 5 years,
It's gone up. Over the last few months, last 6 months, it's gone up.
why do you think that is?
Greater awareness by the surgeons around the implications probably of not working with the pain team and the management of the patients. And I think patients have anxieties and concerns about coming to pain clinics because they feel that they're actually going to have their pain managed and not have the underlying condition managed.
Would they be right?
No, I don't think so. It depends on the clinician. I see a lot of these patients I see in joint clinics, and I've restructured the service recently to make sure that these patients have a proper pathway of care within the hospital, whereby they're triaged as appropriate. If we look at something like endometriosis-associated pains, nurses are quite capable of taking that population on board, triaging them and managing a lot of their fears and concerns, and doctors can become involved in others, and then those more complicated patients I will do in a clinic with my urogynecologist, my urologist and so on, and I've just set up another service parallel to that with another consultant like me who will sit in the clinic with a urogynecologist and nurses, and we have access to psychology and physio. Even in my hospital, management is saying, well, where's the money going to be for this? Because we're taking on board new work, in theory, by restructuring. So it's going to be not complex. So no, we're taking on board, we're the most holistic group. And we've done that for 25, well, since pain medicine started. We're one of the oldest professions, obviously.
So it's not a question that if you get the pain management right, you can actually avoid some of the bigger complications of removals around mesh.
You can, yes.
So that's what I'm trying to get at.
Yes.
In a way, linking then your specialist to specialist centres sort of suggests you need a specialism earlier, lower down, but it's
Yes.
a way of dealing with this so that they don't end up having to have complicated mesh removal surgery.
So the model that we're working on at the moment is that group which people also will say is a surgical decision to remove the mesh, or joint with the patient, obviously. Then there's that group where the mesh is not causing an anatomical abnormality or a pathological process, and that will fall into two groups, as I understand it. One was where the mesh is not quite right, in that it's too high or too low, and does anyone really know what that means? And then there's the group where it's perfect, but they've got all these symptoms. And so in terms of the future, it's really imperative that we collect data on the mesh removal, because in 10 years' time, there's going to be people saying, well, why were you doing that? That group of patients where it's much more difficult to make a decision, the pain doctor and the pain team should be involved much earlier, is my personal opinion, to try and stop that. The issue becomes when you have a patient who is so traumatized by what they've been through that, and we're talking about, I do a lot of work with veterans, so I do a lot with post-traumatic stress disorder. The relationship between PTSD and chronic pain is like this. PTSD goes up with the chronic pain incident. So in those patients who have been traumatized by their experiences of the complications from the mesh for what was a minor procedure, and then who have been going through a process where they've not been believed and listened to, and then have been traumatized by painful investigations and so on and so forth, you need to be managing that before you're making decisions about removing the mesh. The problem is in that group of patients, sometimes they can be determined that's the next thing they want is the surgical removal, so we may not be able to stop that because we have to listen to our patients as well. It's just making sure that they have the information they need.
Well, I guess the question is how frequently and how commonly surgeons would see pain management as one of the early line, or first line or second line options prior to removal of standard sex. Not just in your own screening, but elsewhere.
It's a major problem when we've been saying for 25 years, the publications go back, that all surgeries associated with chronic pain, 10% incidence. That's a figure that we would say that if you're consenting for any operation, it's going to be 10%. If it's a thoracotomy, it may be higher. If it's a vasectomy, it may be 5%, but even simple things are surgery. And so surgeons, we would say, should not operate on the patient for pain reasons. The outcome of operating on the patients because they're complaining of pain can be very poor if that is your first approach, and that applies to everything.
Sorry, how confident are you that surgeons understand what you just said and act accordingly?
I'm not confident.
So
recently, through some of the work that we've been doing, partly through the British Pain Society, and partly by trying to interact with our surgical colleagues, and there was the MESH meeting up in Sheffield. We're getting the message across to the highly specialised groups, and I'm hoping that NHS England will support that if there are those services set up, that actually pain management will be a cornerstone, and it will not be a token cornerstone, it will be a proper service.
Can I ask you, I mean, clearly what you're doing here is a model, intensive in terms of resource and not just money, but obviously expertise. How about the women, though, who just are in such agony, in such pain, that they go to their local area and there's somebody there who's saying, yes, I can deal with the pain for you. What do you, as an organisation, as a society, what do you do in those circumstances? Do you do any further training of those people? How do you...
Okay, so yeah, I mean, our society, as I said, does not recognise bodies. It is based on education and training, and it is primarily to support our members, who are paying doctors, psychologists, nurses, and physiotherapists, to actually support them in their work locally. So to a certain extent, it's about teaching the teachers. And so I would expect the members to be actually going to the local hospitals because of the resource implications. All of our conferences are open to anybody with interest in the field, provided they're professional in the interest in the field. All of our resources are publications, so recently we published publications on things like education around pain in medical schools, where if you're a vet, you get more hours on pain education than you do in a medical school. So now the work that we're doing, some over there, the work that we're doing at the moment is joint work with the faculty of the Royal College, which obviously has more of a official role, as it were, is around medical schools beginning to actually take on board basic pain management strategies and training. That's how bad it is, that we're only there now.
Is one of the symptoms of that a cultural problem within the service? So how would you describe typically the relationship between surgeons and pain management teams?
It's a Cinderella speciality, isn't it? And then I guess it's not for me to. There is, I guess, an element of if you give a surgeon a patient where there's a surgical possible approach, they'll go down a surgical line, and you might say that if you turn the patient to a pain management approach, we'd go down a pain management line. I think pain consultants have had to work across the disciplines because we work with sickle cell disease, we work with cancer and all that. We have to work as a team, and therefore I think you're talking to people who are going to be much more open and prepared to work in that way. Surgical MDT quite often consists of a group of surgeons with similar ideas in the same room. An MDT in my department, got a lot of people there, I would expect 30 or 40 people in that room every week for 1 hour, major resources, talking about the patients with complex drug dependency problems which usually started at St. Elsewhere's. Complex issues psychologically, psychiatrically and socially. And in that room, we will have input from psychologists, physiotherapists, nurses, and doctors. And the doctors will have different interests, whether it be head and facial pain and so on. So obviously, yes, an elite area. But there's no reason why an MDT in a DGH hospital cannot take place with other people, which should include, if not a psychologist, a psychiatrist, though there's differences in their approach, should include a pain management person. It shouldn't be a room full of surgeons. Now, we've started doing a bit of that at UCLH. I've joined, you're probably aware, there's differences of opinion in the teams. I work with both teams. I've always made it quite clear that the services we provide will be equitable for all services. And I was recently at an MDC meeting full of surgeons. I was the only paying doctor there, and it made a difference. I think, they asked me, would I see a patient? I said, no, this is a surgical issue. They asked me, would I see a patient? I said, yes. I think this is an issue where pain management will take part. Unless you actually do that, interact, you're going to have the problem of it's one modality, one speciality making the decisions, and that's not appropriate.
It used to be the case that, in my day, if I could put it this way, that most specialists in pain management came from a background in anaesthetics.
Yes.
Is that still the case?
That is still the case. And it's interesting because anaesthetists are sort of like this, aren't they, in terms of keeping people alive, this, that and the other.
Yeah.
And the background to that was that, and there is still an element of paying doctors going to because they enjoy doing interventions. So I enjoy the neuromodulation, the spinal implants and so on, but there are clear guidelines as to when that should happen, nice guidelines, in fact some of the strongest guidelines out there, the TAG guidelines. So there is that element, and then it is interesting that actually you have anaesthetists with that psychological sort of background who are involved in supporting these sort of patients. Most of the anaesthetists I talk to actually embrace the MDT approach. But what they'll say is that in the small hospitals, they don't have the psychology or physiotherapy.
Can we talk about outcomes?
Yeah.
I think many people, myself included, believe that when you look at outcomes, that it's very important for clinical research and audit to concentrate on outcomes. But particularly look at outcomes in terms of what are the clinical outcomes, but what are the patient-related outcome measures that are the problems of being applied, and the patient experience, and then you have to integrate the cons, the problems, and the pros. And if you can actually look at the overall resource cost of that intervention, you get a notion of value, which is the way of actually trying to make sure that the multidisciplinary teams would approach where the outcomes are positive in terms of value gets properly resourced. So, could you tell me about the outcomes measured in those terms that you get from you're involved in the multidisciplinary team, and also point us to any publications?
So the British Pain Society, I commissioned a document on outcome measures last year. It's a joint piece of work with the Faculty for Pain Medicine, which is Royal College of Anaesthetists, on outcome measures, and that is available on our website. I think it was eventually published after a bit of delay a few weeks ago. So that document reviews all the outcome measures, and those measures are around quality of life measures as well. So they look at psychological, emotional side of things, physical disability, as well as pain scores, which are actually only a part of the issue. If you're looking at outcome measures in terms of procedures and input by the teams and so on, it becomes difficult because of what I'm saying. We're looking at a team approach, and I sometimes will be using a procedure not to cure and get rid of the pain, but actually to be able to work with patients. We're looking at maybe reducing some of the distress, so some minimally invasive type of injections or whatever will help us be able to work with the patient more from the psychology and the pain management behavioural approaches and so on. So it becomes a package that we're talking about. The evidence base around pain management programs and so on, so there are Cochrane reviews and so on. I think this document gave there would be something in there. But there are lots of publications by the King's group, by our group and so on, looking at the evidence base for pain management programs. So
have you published a series of your own team's involvement in pelvic pain?
So pelvic pain, I've been mainly involved as a clinician, and the guidelines struggled to publish because I haven't got the resources, and so it's about what we do. My team has actually collected all the data we've published in terms of posters looking at the amount of distress that the patients have, and that information shows quite clearly that the patients with pelvic pain are of the highest distress group, that the patients with more systemic elements are of the even greater, so if you've got widespread pain as well as instead of just localized. So we've got that sort of data in publication.
And you've got follow-up data.
So we're in the problem with follow-up data in pain patients is actually how do you make sense of it, because of the fact that it's a team approach. So each patient has a personalised treatment plan rather than this being.
No, I understand that. I'm not really seeking an answer to the question of process.
Yeah.
What works,
Yeah.
what's efficacious, if you like. I'm just what is effective in terms of outcomes. But if you've got 100 patients who are referred to you with pelvic pain, going forward at 1, 2, 3, 5 years, have you been able to make their lives more tolerable?
The simple answer is yes, and you can look at it from the perspective of actually, if you look at an individual patient who comes in on a gram of morphine and you can reduce them down to a sensible dose, then that is a direct clinical effect. So from in that sort of way, and obviously looking at medication usage is a reasonable way.
Yes.
We can look at things like casualty attendance. We can look at things like attendance at GPs, and we can show.
But is this data
reduction.
published? That's what I'm seeking.
Some of the data is published, but not specifically around pelvic pain.
Are there any reviews, any papers
So
on
there are
outcomes
papers
on pelvic pain specifically?
by Curtis and Nickel and so on in Canada, which would show that if you have specific programs in specific groups of patients with pelvic pain, but they're not necessarily women.
Because we've heard that there are some women who are suffering terribly,
Yes.
but where mesh removal is probably not possible
Yes.
in its totality. So where do we offer them hope is what I'm seeking.
So it's very difficult to give you the outcome data you're talking about, but on an individual basis, if you look at things like the responses that the patients give us internally about their journeys and so on, and then they will say that actually they're getting an improvement. They're seeing benefit. What you will find though is there will be always some patients who are very distressed, and it is a 3 or 4 year journey to try and actually resolve that. So to monitor that in terms of providing outcome data becomes very difficult.
One of the recommendations, which is part of the pause, is that all interventions should be registered, national database, and then a more complicated registry working with it. But my experience of working in another area is that's hugely valuable, because you can then look at outcome data of 1, 2, 3, which is comprehensive, nobody excluded, and you can then work out what is effective and what is less effective. And I would think that the responsibility of specialised centres should be absolutely to engage in that sort of research.
So there are certain aspects of the data that is being collected and that is being published, but we have to remember that actually we're talking about a large service which has different components, and therefore there are different aspects that are being published on. So as a service, it is committed to publications and research. As a Cinderella service, we have struggled to keep academics. So I stopped doing research 15 years ago, primary research, phenomenological type of research, because of the lack of resources and lack of support, and it's become more and more difficult to be a jobbing clinician as well as to publish those research. We have collected the data on a range of different things, such as sacral nerve neuromodulation and so on. Getting that published as a part-time researcher is really difficult. So that comes down to having appropriate resources.
And you're not actually following that through, you're not recording those interventions on any database. So the pain management side of following a patient who has got pelvic mesh
So
problems.
we've only just got to the stage of there being a national registry for neuromodulation, and even that's not being followed through by all the centres. So there isn't a system for doing that.
Presumably when we're talking pelvic pain, we are not talking just mesh pain, we're talking full range.
I'm talking about full range,
Yeah.
yes. So that's why we've
is there
separated
any
out
way
the
to
mesh
vary?
patients to try and deliver what you're talking about. The initial stage of looking at the mesh patients has been to look at how they compare in terms of distress to the other pelvic pain patients. And the outcome of that is suggesting that they are worse off than the pelvic pain patients, which is worse than general pain patients. So pelvic pain in general and facial pain are amongst the most severely compromised individuals, and then mesh is worse than that.
Do you think with the introduction now of modern technologies in terms of communications and things like that, would that help you?
Is this going back to communication with patients?
Well, it's the database, because it's having to collect the information,
Yes.
as you said, as a jobbing surgeon, pain specialist. You would find it difficult, but we've just been really in another field altogether, looking at how it's in maternity services, how that actually when you can introduce new electronic methods.
So we tried to do that 3 years ago with sort of iPad outcome measures and so on, which would answer your questions, and it was an issue of lack of resources to provide that type of technology. So and that's probably, I don't know what throughput of patients is within our service. And you then have to look at patients who are presenting for individual care, but we also have group programs. The group programs is where most of the data is collected, because that is an intervention that is well defined, and that data, that outcome information is positive. It actually shows that you improve quality of life of individuals living with pain. We run dedicated services, so for head and neck pain, in terms of pain management programs, head and neck pain, pelvic pain, nerve pain, facial pain, and so on. So we have dedicated pelvic pain management programs. We have that data, and that data is published. But individual data for journeys of patients is more difficult. What you're suggesting would be helpful. It comes down to resources.
Can I move on, because I'm conscious of time? NICE guidelines.
Yes.
Are there NICE guidelines on managing pelvic pain?
Are there NICE guidelines on pain? So at this point in time, they're drawing up NICE guidelines on pain, and my understanding is that's going to become primary pain specifically. You then have the arguments of what is primary and what is secondary in terms of things like mesh. So there is an element of, and this is a problem with the WHO guidelines, which several of us have pointed out, is when does something become primary, when does something become secondary. So at the moment they're looking at primary guidelines, and as with NICE, it has to be all evidence-based, as I've indicated. There is a problem in that there also needs to be common sense. So this is like with mesh removal, I can see there's a common sense approach to certain things, and some of it you're not going to have the evidence for. It's the same for pain. Some things are common sense for, and other things there will be an evidence base. I think those guidelines are due to be published in the next 18 months or 2 years are probably not going to be helpful in this situation, and they're going to be more. So the answer is no.
Thank you.
So what would be helpful in terms of guidelines? I mean, in the executive summary to the APGG, you said that specific guidelines for the management of complex issues secondary to mesh are needed. So how would they be useful? Where would they come from? Who would devise and commission these?
Sorry, can you ask it specifically?
In sort of your executive summary to the APGG, you said that there should be specific guidelines for the management of complex issues secondary to mesh insertion.
Yes.
And could you please tell us a little bit more about that?
So this comes back to then, I think, there's several facets to this. There's the pathways of cares that we've alluded to, making sure that we've seen the right person at the right time. The NHS England Service Specification DO7 quite clearly sets that out, and as we've identified, there's a gap in the speciality secondary care services compared to the highly specialised. So that guideline exists as a matter then of implementation of it. The guidelines in terms of pain management exist by things like the EAU and the British Pain Society. So what we then have got to do is look at the relationship between, again comes back to the question over this side, about the relationship of pain specialists, including the team, with the surgeons, and there needs to be guidance from, I think, NHS England on that, as to that, yes, these links are appropriate and should be happening. I think that comes down to a common sense approach. It's much more difficult to actually prove it in terms of evidence base, and that's where I'm concerned about the evidence base. To me, it makes sense that actually you don't have a meeting full just of surgeons, that you have a meeting whereby actually you get representation from other people, and that may include rheumatologists if we're thinking about chronic widespread pain. That will include radiologists and so on. So that's the sort of guideline which probably needs to be drawn up as to how it all fits together, so that it's a pathway that meets the needs of the patients.
So more integrated.
More integrated.
Right. Did you want to come in?
No.
Dr. Baranowsk, this has been so useful, I can tell you. What I'm going to do is to ask my team whether they've got any further questions, just here, and then if there's anything further you want to tell us. So, Sonia, not.
Thank you.
No.
Just one other one, and maybe you might want to write this afterwards. Can you discern from the patients come to you a difference in terms of pain between those that have had pelvic mesh and those that have been treated with more traditional procedures like pelvic suspension?
I think there's a common sense answer to that. I think that those patients who've had pelvic mesh are going to present being more traumatized than if they had pain for other reasons. I guess there is an issue that if you didn't have pain before procedure, and the problem with this is it can be a simple procedure. It can be a colposcopy looking inside of the cervix and have a lady do something like that, or a cystoscopy, or something like that. You go in with a relatively minor problem and then you come out and you end up with chronic pain. Then it causes distress, and that may be childbirth, or it may be something very simple.
Pelvic suspension, of course, is not a minor procedure. So
precisely.
Looking at it as an alternative.
So then, if you look, this is where this is my inclination. Is if you're going in. So my concerns are that I'm not in a position to comment on whether or not mesh should or should not have been used. That's not my skill.
And I'm not asking.
So my concerns are around the consent process and the previous investigations that certain patients have undergone prior to having mesh. It's not my responsibility to say exactly what they are, but having worked in joint clinics with urogynecologists for quite a significant period of time, I consider myself being at a district general hospital level in terms of understanding what I think should have occurred before the mesh was put in. If you then have someone who's been through a process where they've had minor symptoms, some incontinence or something, where they've had minor symptoms, which can be distressing, but they've not had proper informed consent, then they're going to be even more distressed at the end. So if you're having a more major surgical operation, then the complications, you're going to have them explained to you a bit more. Can you take that on board? No.
It's just the difference, obviously, because there are people now saying, we need to revert back, and there's a skill base about who can do pelvic suspensions. But from your perspective, of patients coming to you with pain, just trying to get an understanding if there's a differential between those that have gone through the mesh.
I don't have. I could not give you that data because we haven't got enough information. But there is a sort of common sense viewpoint as well.
Right. Can I just clarify one thing? I think you said that where you're working here, you've got 90 different clinicians involved. Yes, it's very interesting.
So that started from half a dozen of us.
Yeah.
But they're not all involved in pelvic pain.
No.
So we have a facial pain service
that.
and
a
complex neuropathic pain service.
Yeah.
So it is one of the largest services in the world, and it is one of the, if not the largest in the UK. So we're very spoilt, but then we've been supported.
Yes. Well, you have to win support, so congratulations on that. Anything finally you want to tell us?
No, I mean...
You can always write to us.
I'm just advocating that actually pain management services do have a role in the assessment and support of these patients.
Yes.
Difficult to prove it, but to me the common sense is there. If the figures of the percentage instance of pain is going to be variable, but in the self-reported questionnaire it was 100%. So
right.
it's an
Well,
issue that I think
thank
needs to be
you
taken
so
forward.
much. If there are any other further thoughts you have, we're very
you.
open to communications, and do write to us or send emails or whatever. Thank you.
Thank you.
Thank you.